Hi, sorry for that. I started welcoming you all and I was muted, but let's start fresh. My name is Eman El-Menshawy. Good afternoon, everyone, and welcome to 1 year to go inside the IDF Diabetes Atlas 12 edition. Um, my name is Iman. Honored to join you today as an IDF Blue Circle voice from Egypt. And we are delighted to have participants from across the world and advocates and also researchers, health professionals, and policymakers, and actually people living with diabetes, all united by a shared commitment to evidence and action. Before we begin, a few housekeeping notes. First of all, this session will run for 90 minutes. Please keep microphones muted, use the chat for questions later, and remember we will have a dedicated session, Q&A later. The session is being recorded and slides will be shared afterwards. Thank you for being here. Your engagement is what makes the Atlas not just a scientific resource, but a living advocacy tool. So we will start. We will start now by showing you the QR code that you actually can use to have access to this webinar. Next. We just would like to share with you what IDF region are you from, and those who are registered are actually 75% from Europe, 25% from South and Central America, 33%, 29. It's keep on changing because people keep on coming in and accessing this webinar, but it's, as you can see, from all over the world joining the poll. Okay, the QR code is for the poll. So you can join the poll about feel free to actually participate in this poll so we can know better about you and what you represent in your own country. Like the next question of the poll is how familiar are you with the IDF Diabetes Atlas? Whether you use it occasionally, you use it regularly, or not aware of it, or aware of it. So we'll give it some time and few minutes until people actually make their selection. Take your time. Please participate in this poll. It's going to be very beneficial for all of us here at the IDF. The next question, what do you consider to be the biggest challenge in using diabetes data across the countries? Whether it's lack of comparability, inconsistencies between sources, um, limited national data availability, or it's outdated estimates, lack of transparency. The major have chosen limited national data availability so far. Thank you, Aline. I see people also sending on the chat. Please make your selection on the poll. Okay, the next question, how have you used the IDF Diabetes Atlas in your work? Whether it's for research analysis, for teaching and presentation, obviously, for policy briefs and advocacy, or for any other reasons. Okay, until it stabilizes. It seems like for research and analysis is the majority of your selection. The following question is, what would you like to see more of the next IDF Diabetes Atlas? Let's see the options: AI-powered assistance, custom data analysis tools, more language options, translations. Let's see. Seems like the majority chose custom data analysis tools. Very interesting. Thank you so much for taking part in the poll. And now we will be listening to the IDF president, Prof. Peter Schwarz, the president of the International Diabetes Federation. He would love to join us. However, he has sent us a recorded message, and we will be listening to it today in celebration of the 1 year to go inside the Diabetes Atlas 12th edition. So let's hear it.
Welcome and thank you very much for joining this webinar today. I'm Peter Schwarz. I'm Professor for Prevention and Care of Diabetes. I'm President of the International Diabetes Federation. It's a great honor to talk to you about this important milestone, the 12th edition of the IDF Atlas. The IDF Atlas, the World Diabetes Atlas, is our hot-selling product and provides credible and authoritative data on diabetes worldwide. Over the time, it became the most widely cited advocacy tool for the global diabetes community, supporting any one of us, but also organizations, researchers, healthcare professionals, and many, many policymakers. And this is good. Reliable data are needed, and they are essential to drive change. Policymakers will use this data to think about policy, develop new policy, and translate them into action. The IDF Diabetes Atlas helps the diabetes community to demonstrate the scale of urgency and what challenges we have to address, but also to strengthen advocacy and better prevention strategies, improve care and policy. We will hear more about the IDF Atlas in a few moments, just highlighting a few figures. 589 million adults living with diabetes worldwide. It's 11% of the global population. And this number will rise to 853 million by 2050 and probably even more. And these figures show us we have to act, we have to do something not to allow this development coming into place. In today's webinar, the IDF epidemiology team will explain the full production process of the IDF Atlas and how to use it, how to interpret it, and how to set standards with this Atlas. But the important point is your contribution helped to assure that this next Atlas reflects the true diabetes situation in each country as accurately as possible. Therefore, I would like to thank every one of you and would like to thank also all our speakers for talking about it, for putting together the data, but especially all you listening to contribute data and to use this data to translate them into action. I wish all of you a very informative and fruitful discussion, and I look forward to seeing you again at another IDF online event. Thank you very much.
Thank you so much. And now we will be setting the scene with 26 years of the IDF Diabetes Atlas Advancing Global Diabetes with Prof. Diana Magliano. I hope I'm pronouncing your name correctly, Doctor. And she is the IDF Diabetes Atlas co-chair from Australia. Welcome.
Welcome, and thank you for joining today's webinar. Today's event is a key moment as we begin the 1 year countdown to the 12th edition of the IDF Diabetes Atlas. Over the past 20 years, the Atlas has consistently delivered valuable and accurate and realistic summary data on the state of diabetes for each nation and the world population. Now, one of the key challenges we face in accurately capturing the global impact of diabetes is a limited data availability in some parts of the world. In our previous edition, about 30% of all countries did not have their own data for us to use in our modelling. As we begin preparing the next edition, we are therefore issuing a call for additional high-quality data sources. Your contributions are essential to ensure that the next atlas reflects the diabetes situation as accurately as possible in each country, and we'd like it to be very comprehensive. We really appreciate your support and collaboration in this effort, and I really hope you enjoy today's webinar and find the session informative and engaging. Thank you very much for listening in.
Thank you, Doctor. And we will be moving to our next speaker about the production of the IDF Diabetes Atlas and how the atlas was produced in the first place. It's about data collection, critical appraisal, and modeling and validation. We have Dr. Irini Genitsaridi. I hope, again, I'm pronouncing your name correctly, Doctor. And she is an IDF data scientist from Greece. Welcome, Doctor.
Hi, everyone. In this webinar, we will produce how the atlas is produced, data collection, critical appraisal, modeling, and validation. Next slide. The analysis of the atlas covers a list of countries and territories based on the United Nations classification. The list is updated for each edition according to data availability. In each edition, data availability is assessed across IDF regions: Africa, Europe, Middle East and North Africa, North America and the Caribbean, South and Central America, Southeast Asia, and the Western Pacific. Next slide. An updated review of published and grey literature from the past 3 to 4 years is conducted for each edition. Data are compiled from published studies, national registries, unpublished surveys, and WHO step studies. Published data are sourced from Ovid Medline, while unpublished data are obtained through IDF regional offices across all regions. Inclusion criteria for data sources are population-based studies, sample size greater than 200, and reporting of diabetes in greater than 3 age groups. 2 independent reviewers evaluate the full text of the selected sources, with discrepancies resolved by a senior reviewer. Population and urbanization data are sourced from United Nations Population Division. Next slide. Study quality is assessed using the analytic hierarchy process, which weights diagnostic method, sample size, representatives of the data, study year, and publication type. Studies with low AHP scores or conducted before 2005 are excluded from the analysis. For each country, the highest scoring study and any others that are within a small difference of it are selected for analysis. Next slide. Diabetes prevalence estimates are obtained from each data source, stratified by age, sex, and urban and rural location. Because reported age ranges vary across data sources, regression modeling is applied to each data source to generate smooth prevalence estimates for 5-year age groups among adults aged 20 to 79 years. Studies based on self-reported data are adjusted prior to smoothing to account for undiagnosed diabetes. For each country stratum, diabetes prevalence is calculated as the AHP weighted average of smooth values from the available data sources. The number of adults with diabetes in each stratum is calculated by multiplying prevalence by the stratum population size. National prevalence estimates are obtained by summing the number of adults with diabetes across all strata and dividing by the total population. Next slide. Global diabetes prevalence is calculated by dividing the total number of adults with diabetes by the global population aged 20 to 79 29 years. Estimates for subgroups are calculated in the same way. Estimates are generated for the 3 World Bank income groups: high income, middle income, and low income. Estimates are provided also for all IDF regions and are also provided by sex, urban-rural location, and for older adults. Projections are generated for the next 25 years. Next slide. Extrapolation is applied to estimate prevalence for missing data. For countries without in-country data, estimates are extrapolated using data from countries with similar income levels, geographic region, ethnicity, and language. Country extrapolation groupings are revised in each Atlas edition by the expert committee based on data availability. Next slide.
Thank you so much, Doctor. And now we will be talking more about 1 year to go inside the Diabetes Atlas 12th edition, preparing the 12th edition. Call to the diabetes community to contribute studies and actively participate in the data collection process. A presentation by Dr. Paraskevi Salpea. It's an IDF epidemiology manager, and she is from Belgium. Hi, Doctor. Welcome.
Hello from me as well. Thank you for the introduction. Before I start, I want to say thank you, Irini, for the presentation. And this summary of the methodology of the Atlas, you can always find it on the Atlas website in the Atlas printable version on the chapter 2. You can read more details about the methodology, and also in our published papers, again, also can be found in the resources on the Atlas website. Today, we actually want to expand a call for a collection of data, and for that reason, we wanted to present the Atlas, and I will just give a quick overview and what resources are available and indicators before I give you specific information about the data we are looking for. Next. So as Irini just presented, we are having a specific process to fulfill the Atlas. We are 1 year to go. The launch of the Atlas 12th edition will take place in April 2027 during the World Diabetes Congress in Qatar, Doha. Currently, we are doing the data collection. Therefore, we are calling for data from the diabetes community. And we are revising our methodology. Every Atlas edition, we revise our methodology. We try to improve our methodology to provide better quality and more data for around the world. The next step is the most important, let's say, period of the Atlas is the analysis of the data. This takes a long time because we don't only present, as I will soon mention to you, diabetes in adults, but could present multiple indicators for the diabetes impact. And all our data, methods, analysis, results are extensively reviewed by a committee of scientific experts on the field of epidemiology and diabetes. And this is what enhances the credibility of the Atlas. Once the data and the results are cleared by the scientific committee, we continue into the content development and the design. Next, please. Once the content and the design is available, what we are trying is to offer as many resources and as many outputs of the Diabetes Atlas as possible, of the estimates, to be used by the diabetes community, the advocates, and that includes a website dedicated to the IDF Diabetes Atlas with a data portal. There is an interactive map that somebody can directly access the data. In addition, what we always offer is an Atlas printable version that all these resources can be freely available online and can be downloaded for free. A PowerPoint presentation, this can be downloaded and the slides can be immediately used for presentations, policy briefs, research, lectures. Fact sheets, we present a 2-page fact sheets with key messages, top countries, key estimates, and these fact sheets, we provide them for every IDF region and for the global data. In addition, we have peer-reviewed articles. This ensures the credibility of our data, and the users can read more about the methodology and the data. The last IDF Atlas was published in a Lancet publication, and you can always find these resources in the Atlas website. In every edition, we try to improve and provide even more outputs for advocacy and other activities. In the next edition, based on a survey that we did in our users, and we always take into account the Atlas users' feedback, we have some interesting suggestions to add infographics, case studies, more advocacy material, but also AI assistant for data retrieval. And I have to say, I also saw here ranked #1 from the participants of this webinar was the custom data analysis. This was also in the Atlas survey, not on the top 5, but it's good to take into consideration. I have to say we are taking it into consideration on the design of the next Atlas edition. Next, please. Here, Irini described us all the process of from data collection to producing the Atlas estimates. But I want to say that the IDF Diabetes Atlas not only provides the diabetes estimates in adults around the world, we also provide additional indicators important to describe the full impact of diabetes. This is undiagnosed diabetes, diabetes-related mortality, diabetes-related healthcare expenditure, other types of diabetes such as gestational diabetes, pre-diabetes, and type 1 diabetes across all age groups. In every edition, we also have additional content that is either diabetes complications, which is a very important aspect of the diabetes impact, but also other related diabetes topics, such as in specific populations. In the next edition, so far, what we are planning to add is analysis estimates on diabetes and liver disease and diabetes and stigma. In addition, we have partnered with World Diabetes Foundation in this edition, and in a collaboration with them, we're planning to present from their programs successful examples of case studies, country case studies, with proven interventions, measurable impact, and best practices, and this will help us to inform future initiatives. Next, please. Going now in the call for Atlas data, as the diabetes co-chair Professor Diana Magliano mentioned, and Irini also in her presentation, one of the main challenges of the IDF Diabetes Atlas is the lack of data for some countries. And lack of data meaning not also lack of data, but lack of good quality data. 30% of the countries on the last edition didn't have in-country data sources. It is very important for us from edition to edition to decrease this number and try to provide estimates as accurate as possible. For that reason, we call the IDF network and the IDF community to contribute with studies from your countries for the 12th edition. IDF uses a variety of high-quality data sources and in its model, generates national, regional, global estimates of diabetes prevalence. Thus, data sources should satisfy the minimum of diabetes prevalence stratified by at least 3 age groups. If the data are also available by setting and sex, are preferred. A systematic process is used to determine if studies can be included. This involves scoring the of research quality using the analytical hierarchy process. Irini made a more detailed description of that. Can we go to the next slide, please? Thank you. So studies with the following criteria have the greatest chance of being selected. That doesn't mean that they only selected that, but this is preferable. Studies with large sample size, national representative ideally, but we take into account sometimes regional studies as well. High response rate conducted in the last 5 years. Again, these are studies that we give higher score, but we take into consideration in our scoring all the studies after 2005. Published in a peer-reviewed journal is also a strong criteria for the studies that we select. And also diabetes case identification by OGTT, fasting plasma or fasting plasma glucose or HbA1c. Next slide, please. As I mentioned, beyond diabetes prevalence in adults, we also welcome data sources or studies that have been conducted and present in your country the prevalence of undiagnosed diabetes, impaired glucose tolerance, impaired fasting glucose and prediabetes, gestational diabetes, and mortality. Studies that have not yet been published can also be included if sufficient detail of the data collection methodology can be provided. high quality studies and information from on national registries are also welcome from all countries. Next slide, please. This information that I just described, you can find it in the recording of the webinar, in the slides as well, but also all the information that I just shared is available in the Atlas website. In the main page of the Atlas website, we have the screenshot that you just see that you can contribute study data for the 12th edition. You can click there and be addressed to this web page below, where you can find all this information and how to submit your data sources. And at this stage, I have to say that we had a very good response from diabetes community. We have already received a lot of data sources, and thank you all who sent. And please, if you are aware of any national health survey in your country publication, please share it with us, and you will find how to share it and exactly what type of studies we are looking on this link. Closing, next slide, please. More importantly, acknowledgements. The Atlas is a collaborated effort of the IDF, but the credibility is relying on the scientific community, the experts on diabetes and epidemiology. I would like to thank Professor Diana Magliano and Professor Eduard Boyko. Their role in the Atlas is very important, and our credibility relies on them and the other experts. And finally, of course, the sponsors of the Atlas 12th edition are long-standing sponsor Sanofi. And as I already mentioned, we are happy to partner for this 12th edition with the World Diabetes Foundation. Thank you very much for your attention.
Thank you so much, Doctor. Very informative. And now we will be tackling how the Atlas supports advocacy. It's my pleasure to be one of the advocates who would be talking about how the edition of Atlas actually helped me in content creation, let's say, and being an advocate. Because at first, when I began my blog, which is it's called Eman Diabetic Diaries, it was a personal blog, a space to share the live reality of diabetes in Egypt. But I quickly realized that stories alone, while powerful, needed to be anchored in evidence to drive change. That's where the IDF Diabetes Atlas became transformative. When I first began the page, or Eman Diabetic Diaries, it was a place to share. But as a communicator, I learned to translate numbers into narratives. For example, when the Atlas highlighted rising prevalence into the Middle East and North Africa, I used those figures to frame stories of families in Cairo managing diabetes, let's say, in different situations during Ramadan. And suddenly my blog was so relevant to so many people. And it wasn't just storytelling, it was evidence-based advocacy. And this credibility opened doors with a lot of entities, foundations, and companies, whether pharmaceuticals or others, like Masr Al Khair Foundation, where you can see some of the pictures where I actually worked on initiatives that emphasize capacity building and sustainability, ensuring that advocacy was not just charitable, but empowering to our community, people living with diabetes. And later, Eva Pharma, for example, chose me to represent the launch of the very first insulin manufactured in Egypt, which is a breakthrough that now supplies affordable, high-quality insulin across the Middle East and Africa. And being selected for this role was a recognition of how my journey had evolved from content creation or content creator to trusted advocate, representing Egypt and the region in a historical milestone for access to essential medicine, and all of that because of the reliable information and statistics that I could found in the Diabetes Atlas. Over time, this combination of evidence and lived experience helped me to grow into a community leader. Today, as a Blue Circle voice, I continue to use Atlas as both a compass, guiding responsible advocacy, and a megaphone, amplifying the voices of people living with diabetes in Egypt and beyond. Thank you so much. And this would be my word and my contribution to how the Atlas actually helped me being the person I am today and being a health advocate and be most importantly, people or a person living with diabetes. So next, We will have a recorded message from Mr. Pedro Al-Deljani, who is a Dialab and Lebanon's young leader in diabetes, a national focal point for the National Diabetes Program's implementation project under the IDF, and he is from Lebanon, sharing with us how the Atlas supports advocacy from his perspective.
Good day, everyone. Before I begin, I just want to apologize for not being able to be with you here in this webinar live. I'm currently on my way traveling to Jaipur to attend the Global Diabetes Stigma Summit, but it really means a lot to still be with you virtually. And I'm looking forward to meet a lot of you in person in the upcoming days. My name is Pedro Al-Deljani, and I'm 27 years old, and I've been living with type 1 diabetes since 2016. I've been able to live a healthy, active life, and that's exactly why I'm here today. Not just as a patient, as a political scientist, a diplomacy student, and a representative of Lebanon, Dialab, and the young leaders in diabetes programs with the International Diabetes Federation. When I first got diagnosed, I thought diabetes was only about insulin. But over time, throughout my studies in politics, I realized diabetes is something bigger. Diabetes is also about policy making. In diplomacy, we always say, if you want to solve a certain problem, you need a shared understanding. You need data. For us, that shared understanding is the International Diabetes Federation Diabetes Atlas. Let's look at our region. I want to give you two examples, Lebanon, or I want to start with the Middle East and North Africa, the MENA region, which has one of the highest diabetes rates in the world. And it's rising fast. I'm going to be specific, Lebanon. Lebanon used to have 480 people living with diabetes, 480,000 people. Now we have approximately 527,000 people living with diabetes, and we can check, and I endorse you all to check these numbers on Diabetes Atlas on the website. Yes, it's not just a number. We're talking about 12% of the people in Lebanon are living with diabetes. Their family members, friends, people from our communities. And yet millions are still undiagnosed, and we know it. We know it through our activities. Diabetes is invisible, and in policy making, if something is invisible, it doesn't get funded. That's why Atlas matters. It makes the invisible visible. It gives us a common language that governments can trust, beyond politics, beyond borders, beyond everything. Diabetes doesn't have any ethnic group, neither a religion. We're all human beings, and we're all simply living with diabetes. Because diabetes has no borders, so our response should be borderless. In my role as a young leader in diabetes as national coordinator, my job is simple. Take data and turn it into action. In Lebanon, we use these numbers to push for real strategies. For example, when we show a policymaker how many people are affected, suddenly it's not an abstract anymore. It becomes a priority. We also speak the language of economics. Invested in insulin and early diagnosis is not a cost. It's a saving, because without health, there's no strong economy. So where do we go from here? Firstly, we expand screening to find those who are undiagnosed. Secondly, we ensure access to insulin and technologies like CGMs, like pumps for everyone. Thirdly, we strengthen regional cooperation to reduce costs. In the end, it comes down to this. Data is our foundation, Diabetes Atlas. Diplomacy is our bridge. Through advocacy to have access to care is our goal. It all starts from the basics, from the roots, the Diabetes Atlas. I'm standing here today as proof that when people have access to information, access to data, access to numbers, they don't just survive, they lead. Let us use the Atlas as our guide and move forward together.
Thank you so much for Pedro, who I'm sure will be listening to our message as well. I hope you guys can hear me. Please let us know if you can see and hear the webinar still. And we will move to the next advocate, Mr. Evgeniy Nikolaev, who is a co-founder and IDF Blue Circle Voice from Russia, Argentina. And he would be talking to us about how the Atlas supports his advocacy work.
Hi, my name is Evgeniy, and I help my clients to reverse type 2 diabetes, and I'm a very proud member of Blue Circle Voice, and I'm leaving the Atlas myself. Thank you for all the previous information which was provided. I am 1 in 9 people who live with diabetes type 2, and we have 95% of those who live with type 2 diabetes in 589 million people, and I'm one of them. There is a picture which you see on your screen, which shows 2 stages of my diabetes, and between those 1 year, where I have a lot of suffering, a lot of fear, a lot of frustration, and trial and error. Now I live my life with remission of type 2 diabetes for 2.5 years, no medications, no surgery. But before that, I hit my rock bottom when it was, I still remember that, and it's in front of my eyes, you know. When we went together with my wife for a dinner, and I couldn't raise after it for 40 minutes from the table because I had I've been very pale and white, and I had all of my sweat going on, like cold sweat. And my wife said, check your blood sugar, please. And then I've seen my anti-record 23.4 on glycemimeter, which is around 450 in American metrics. And at that point, I was struck by fear of sudden death from diabetes. Yeah, I've seen, for whom I would leave my son, I thought, yeah, that's the end. By that time, I'm already on 3 medications, and I'm religiously following the diet which my doctor tells me, but that doesn't prevent me from that deep moment of disappointment, deep moment of fear, and that was very, very strong moment for me. I seen in my life now not only that sudden death fear, but also I almost lost sight to diabetes. In 3 years, I've lost it only to 20% of what person without diagnosis could see, just because of the diabetes. I had a significant issue with my erectile dysfunction. I had cases which was extremely painful for a newlywed. And now I'm remission. I'm full of youth, full of strength, and I feel myself healthy again. And I try to help others as well with this particular condition, but there are too many. There are several hundred million people who suffer from diabetes type 2, and thanks to Atlas, we know it. We know how hard that truth is. And it's very difficult to comprehend it unless it's written in scientific and described very meticulously in scientific way, and it's a recognized source. For me, I'm leaving that Atlas at this point. I am the atlas in a sense, that I am part of those numbers, but I have all that particular personal pain regarded to it and the joy of overcoming that. I come here to celebrate the day of this atlas being released for a year, and recognizing the importance of it for really tackling this existential threat, existential to humanity, because it's overwhelming. And even if I have my following of 55,000 people, it's still a drop, a single drop in the ocean of the problem. Thank you very much for listening.
Thank you, Mr. Evgeniy. And now it's the time for the discussion panel and Q&A. So feel free still to send your questions so we can actually go through them and address them to the doctor and professors we have today on our webinar. First question is for Prof. Irini. I have been following the release of data from the Diabetes Atlas since the first edition. What has changed is her question.
With each edition, data sources are updated and methodologies are refined, and country-level urbanization and population estimates are refreshed. Extrapolation regions are also revised to reflect the latest data availability. Additional indicators were also added over the years, such as IGT, IFG, gestational diabetes prevalence, complications. Thank you.
Okay, so next question is for Prof. Evie. What are the main challenges in compiling the atlas and collecting reliable data? What methods are used to gather and update the information? Doctor?
Thank you. So the main challenge is what Irini have mentioned in her webinar and I have mentioned afterwards is the lack of data. And like I said, in the last edition, 30% of the countries didn't have good quality data sources. So it's very important to gather good quality sources to be able to accurately describe the impact. What are the methods we are using? First of all, we do a systematic literature review. We, like Irini described, we evaluate the published studies the last 3-4 years. But very important then, it's also to gather national health surveys, ministry data, registries, even unpublished data if there is enough information. So there, IDF has a very strong element. We have this extended network of diabetes association, more than 250 across the world. So we extend a call to send us data from their countries, but also that goes out to our networks of advocacy networks, like you, Iman, Pedro, Evgeniy, everybody who are aware of a national health survey in the country, publication, that they can share the data with us. It's important to take advantage of this extended network and activities like today that we extend a call to the diabetes community overall to send us their data. So I think this is the biggest challenge in the Atlas, accurate data from all the countries and especially low and middle income countries.
Great, great. Thank you, Doctor. And next question will be for Prof. Irini. What confidence do we have in epidemiological data and diabetes prevalence and mortality rates?
All estimates are presented with confidence intervals at the global, regional, and country levels. For example, the global prevalence estimate for 2024 is provided with upper and lower bounds. The level of confidence varies across country estimates. We are also trying to improve from edition to edition. Atlas 11th for the first time estimated mortality, specifically for diagnosed and undiagnosed diabetes. Thank you.
Thank you, Professor. So the following question is for Prof. Evie. Are the data collected from private and public medical institutions only from, that was the question, from medical from private and public medical institutions? And the remaining of the question is only diabetes institutions or general hospital clinics?
Yes, so we don't have a limitation of where we are taking our data. The criteria we have is that the design of the study. So in order to be able to evaluate accurately how many people have diabetes in the world, we have to gather studies that they are population-based. So for example, if there is data from a clinic, then it's disproportionately representative of the diabetes estimates in the world, because it's specifically on a clinic that probably people with pre-existing conditions, with comorbidities go. So what we are looking for is population-based and not from what they are coming from. They can be published by academic institution, by a clinic, but as long as it's population-based, then we are taking them into consideration.
Thank you, Doctor. Next question is for Dr. Irini. Given the prevalence estimates vary depending on study methodologies across countries, how is the most appropriate data selected for inclusion in the atlas? The same for you again, Doctor.
Basically, an expert committee determines which study methodologies and data sources meet predefined quality criteria for inclusion in the atlas. The quality of these sources is then assessed using an analytical hierarchy process with different weights assigned accordingly. Final estimates are calculated using those weights. Thank you.
Thank you, Doctor. So the next question is actually addressing Mr. Evgeniy and myself. I'll leave the floor to you first, Evgeniy. How can people living with diabetes translate Atlas data into meaningful change in their communities?
Yes, I think it's great question. I think it's the most important part is authoritative opinion, which can be gathered from the data when you speak to somebody in your local community, because you can refer to that particular data and also can share the word not only from this edition, but previous editions and future editions as well. I think that is a great option to use the Atlas for.
Right. And if I may answer this part of the question, I would say it's very important to me, at least, to simplify the information and the data. Not everyone is a professor or a doctor or a scientist. And I guess this would be my strength points, because I had the privilege to transform the data, the numbers, the very complicated, might be complicated information to the public into a storytelling kind of piece of content. And it made people more interested, let's say, and it's because it touches them. So I got the power and the reliable resources from the Atlas, and I managed, like, there is a skill needed in between where it can be broadcasted to the mass and to the public and to the people, but in a way that is relevant to them. And this always is needed to be strengthened by reliable information. So whenever I do that, I am using a reliable information like Atlas 12th edition, let's say, and that made my blog more trusted, because even if someone would like to go back and double check the resources, they will find that it is written, and actually people do that, especially that the Atlas produce its editions in many languages, including the Arabic, and it's my main mother tongue. So this is how it is beneficial to the community I'm in. So thank you, Ivan. And for Evie, how can we achieve, this is the next question. How could we achieve better data and rates relating pre-existing diabetes? For example, the differentiate between diabetes type 1 and diabetes type 2.
I just, before I go on, it's like I have open ears and it's good to have these discussions with advocates. Like I'm listening to you about the storytelling, so I'm keeping notes, I have to say, for the next website. So I hope we always meet, the standards, trying to provide as much as possible information that can be used. So going to the question is how we can differentiate between type 1 and type 2 and relate. So this is again has to do with limitations in the systems and data globally. We already presented the challenges we have for getting good quality data sources already without differentiated. Imagine if you reach the level that you want studies enough from all the countries that differentiate between type 1 and type 2 diabetes. So enhancing surveillance systems in countries, and national data systems and registries, the use of registries in countries could help. And of course, standardizing definitions and methodologies. If there is not a standardized methodology, there is mistakes on diagnosis, and all this can lead to lack of data sources. And like I said, we are already, by looking for total diabetes studies, we have challenges of gathering data sources around the world. Imagine at this stage going into differentiated between type 1 and type 2, it needs more time. But I think enhance national surveillance systems that will help in general Atlas and other tools that they evaluate the prevalence to give accurate estimates, but also registries and standardized diagnostic methods. Yes, that's something that could be useful. Thank you.
Thank you. Thank you, Doctor. And for Dr. Irini, how does the International Diabetes Federation address data gaps and limited surveillance system in low and middle income countries?
Extrapolation country groups are defined in each edition based on similarities in ethnicity, language, income, and data availability. Low and middle income countries with limited data borrow data sources from their respective extrapolation groups. We are trying to minimize these cases by calls for data to our network and diabetes community. Also, every edition has a new systematic literature review to capture new studies. Thank you.
Thank you, Doctor. A question coming our way. Please be reminded that you can post your question on the chat and the team will gather all the questions so we can address it to our professors and professionals who are honored, that we are honored to have. The next question is for Mr. Evgeniy and myself again. What strategies are most effective in using Atlas data to influence policy, particularly around the affordability of medicines and technologies? You can start. Yes.
Okay. Yeah. Thank you, Eman. What are the strategies? To speak up about it, because I see in some of the countries there are people who live with type 2 diabetes coming from. For them, it's pretty difficult to speak up with the authorities and say to them that the emergency of necessity. For instance, in one of the countries is Kazakhstan. They start approaching Ministry of Health regarding the supply of medicine and technologies towards diabetes type 1, type 2. And I think that sort of move can allow policymakers to think about it and to make considerations and take decisions informed from the side of people who suffer, who live with diabetes type 1 and type 2. Thank you.
If I may also add to this point, I do agree that we need to speak up, but also I would like to simplify things, even like strategies and reaching out to decision makers. And I would start small. This is how I started. I shared my own journey. Again, back to the storytelling. It was very real. It was very honest and genuine. And then not only people were interested in what I say because whether they are diabetic themselves or they have a loved one who like have the disease and they don't understand anything, but they want to be educated. Then the policymakers were interested to know more about the community because there was a community around me that started to form. Peer support groups, even if it's online groups, helps a lot because it forms some sort of a coalition, some sort of like a power that cannot be ignored. And I would say that staying focused and being genuine, again, in what you can do best. If I can say my story, if I can share my story in a good way, then I will do. Because also when it comes to advocacy, it's different from a country to another, from a context to another. In my case, and again, I would refer back to the presentation I did regarding working with NGOs and working with even pharmaceutical companies. I was just present online with all genuinity. And then people started to hear me, to listen. And I don't represent myself, I represent my entire community. And I think this is the main focus, is that you are genuine in what you do, depending on your context and your country. So let's go to the next question from our fourth doctor, Evie. I wanted to know if the Atlas will present statistical data on the prevalence of cardiometabolic syndrome.
Sorry, I was muted. We had actually recently on the last edition, like I said at the beginning, we have some stable contents that we have in each atlas, indicators like diabetes in adults, type 1 diabetes, gestational, and there is some additional topics that vary from edition to edition, usually complications. Last edition, Atlas 11, we had estimates about cardiovascular disease, and we had some key numbers about heart failure in people with diabetes, hypertension. So I'm invite you to go to the Atlas 11th edition. Now for the metabolic syndrome, I don't think we had so far in the Atlas data. It always, how we are deciding on the topics that we're going to do in the Atlas, it's a collaborative process between the Atlas team, our community, what is being asked from feedback from the community, and also very importantly, it goes through the Atlas committee. The Atlas committee evaluates whether there is enough data to be able to gather them and give an accurate picture about the issue, because one of the main strengths of the Atlas is the accurate and credible data. So far we haven't done for metabolic syndrome, but we had for the cardiovascular disease on the last edition, and noted, and it will be under consideration with the committee and maybe next editions.
Thank you, Doctor. Following question is for Dr. Irini. How can advocates and policymakers confidently use diabetes atlas data in settings where local data is limited or uncertain?
Reporting estimates alongside confidence intervals is critical when data are limited or uncertain. Decision making should also involve domain experts to assess whether the level of confidence is sufficient to support actions in these settings. Distinguishing between country estimates that include in-country data sources and those that do not is very important. As is transparency, transparently reporting data sources and analytical methodologies. In Atlas, there is detailed published documentation of the extrapolation strategy to ensure accurate estimations in countries without data sources. Thank you.
Thank you, Doctor. The following question is for myself and Mr. Evgeniy, so you can start. How can policymakers use IDF Atlas data to design effective programs that reduce diabetes stigma?
Yeah, thank you very much for this question. I think that's getting stories out, stories of people living with type 1, type 2, LADA diabetes out, and showing that to normalize that condition for people can really reduce the stigma around it, because when people start sharing, start taking it to other people to be aware, uh, even though those who don't have the diagnosis, that will allow to speak up and to make sure that the policies which are addressing that and which are showing that stories can reduce the stigma. That's for sure, because through personal point of view to people who are around, that's what I think can be used for this. Thank you.
Thank you. And I would also agree with you, Evgeniy, but I would say as well, when it comes to policymakers and decision makers, is to rely on reliable sources and make sure that it's provided and produced within their own context and their own country. Like, for example, the professors we have here, they've mentioned so many times that in, let's say, in the middle income countries and low income countries, the data is not so reliable. They cannot really count on it. So maybe it would be very beneficial if they would help supporting the IDF work and Atlas production, as well as eventually, when information are out there, is to take it seriously and design intervention based on it. And it doesn't have to be like a big thing, but only if they start with education. And I always say, like, being a diabetic person myself, and what I see around me, diabetes is a disease that needs the patient himself, herself to be educated. And that needs a parallel education other than the ones that we have in schools. So this would be my part answering this question. We have another question for Professor Evie. What will the 12th edition do differently to ensure that data from low-income settings is not only improved, but actually used to inform national policy?
Yes, that's a difficult question, but I think the one brings the other. If they are improved, they're going to be used for national policy, more accurate. So I think one of, like we discussed today, it's the main hot topic to improve is to gather good quality data sources, advocate for national surveillance systems, registries if they're not. Besides gathering and providing as IDF Diabetes Atlas project more accurate estimates for these low and middle income countries, what we will do to make sure that are being used for national policy changes is take the advocates' input, the users' input of what kind of resources to provide. What do you need? You said storytelling. From other feedback we have heard, we want case studies. We want custom data analysis. We want AI-powered tools. So we are taking that into consideration, and with the resources that we are already providing, we are trying to provide additional resources to make sure that we, give the tool, the weapons that our advocates need to go out in the battle. So improving the quality, the credibility, and also providing as many as possible sources based on the feedback we get from our users. This is what we can do. And of course, as IDF in general, not only as Atlas, by doing activities as here in the webinar, the publications, podcasts, disseminate information, bring the message out there as IDF. That's also helpful for enhancing, held countries accountable on the situation. So.
Great.
I mean, I think you can also tell me, Iman or Evgeniy, what you think there, because what you would think could the IDF Atlas provide, to make sure that can be used in national policy changes. But I think you already told us, with the personal story, with the storytelling, and but yes, I'm looking into you. I think you are the best resource of advice for improving the Atlas, to be honest.
But I think, Doctor, you've said, or you've shared like a very key statement. It depends on the data provided.
Mm-hmm.
So it's also needed to be obviously it's designed well, but disseminated in our own countries, how it's going to be used. And that's actually was one of my questions, is how can advocates, how can anyone for that matter, can support the production of the atlas? As a diabetic person, and also as people living, like there is also this very interesting term, co-survivors, like people
Yes.
living with people who are living with diabetes, because that matters.
So I think your engagement is all like the Atlas. We are to serve the community. Of course, the community can serve the Atlas if you are aware of a national study, if you can advocate for surveillance, if your country doesn't have data in the Atlas and you can advocate also for better surveillance systems, then you are also helping the Atlas and vice versa. So being active as an advocate, you're already helping, and being active means giving your feedback to the Atlas, telling what you need. I think this is what is ideal for us, and we are already improving because of that. So the Atlas started with a printable version, like a book that you could print, and now it's an interactive data portal with fact sheets, with PowerPoint presentation, and I think all this is taking into consideration the feedback from the users, and I believe in the future there will be even more coming out. So your engagement, you're advocating in your country for surveillance systems and good quality data sources. What else could we ask for the Atlas? And actually you using the Atlas data and hearing your story, Pedro's story, Evgeny's, I mean, gives also a different meaning for me and Irini working for the Atlas, to be honest. It's you from research to immediate, use, implementation. So I think it's a great example.
Great. Thank you so much, Doctor. The following question is for Professor Irini about the extrapolation for countries where data are not available. What are the key points you take into consideration to extrapolate?
In each edition, extrapolation groups are revised, so the expert committee decides on which are those regions, and this is decided based on the study characteristics along with the data availability for those regions. So in each edition, we exclude older studies and we include new ones. Maybe data scarcity changes over time. Hopefully, we have more data in each edition. So extrapolation groups are the basis to derive estimates for countries that have scarce data and limited data sources. Thank you.
Thank you, Doctor. And I guess we're done with the information. Or sorry for the question. No, more questions are coming your way. So for Professor Evie and Irini, actually, in many low and middle income countries, most available data on diabetes complications such as CKD come from hospital-based cohorts rather than population studies. Can such data still be useful for regional estimates or future atlas analysis?
So Irini, maybe I can start and you can add as well. So when I said population-based, it's on the diabetes prevalence, how many people have diabetes in the world. When we are having to do with complications, then it's a different methodology. Of course, when we provide the data of chronic kidney disease or cardiovascular disease, when this analysis was done, was taken into account data from clinics or diabetes clinics. So what I mentioned before, population-based, that had to do with diabetes prevalence in the overall population, not with the complications. There is a different methodology. There, hospital and clinical data will be taken into consideration, of course.
And Dr. Irini, would you like to add to this?
I think Evie mentioned all the points for
have
this way.
covered all. Okay, great. So, so the next question is for again myself and Mr. Evgeniy. How can this resource be effectively used to advocate for improved services within the healthcare system?
I think, thank you for the question. I think that's to be on top of priority for endocrinologists, and to see the magnitude of the problem, and I mean, to be aware and helping others through spreading the word out. Also, I see a role of IDF certified diabetes educators as one that will help the system to work better, because I'm accomplished the course from IDF, and that's very in-depth, and allows me to speak with professionals about this disease, and knowing how to add up value. I think Atlas and the courses from IDF can be very resourceful for healthcare systems. Yeah, thank you.
I echo Evgeniy in this point. He covered it all. Are there more questions coming? Okay, so can the Atlas team and add tips, guidelines for researchers and advocates in places like Sub-Saharan Africa to help gather vital and helpful data?
That's for me, or it's okay. I can
Whoever is
reply.
relevant
Yeah.
to.
So
I'm sorry, it's
yes,
not specific.
I think this is a very important question. We already have guidelines of how to conduct epidemiological studies, and these guidelines can be downloaded from the resources of the Atlas website. And there was also a course developed with these guidelines with the IDF school, and I invite you to visit the IDF school. There is a course you can follow for how to conduct epidemiological studies. Now, for the criteria, you can also refer to the summary of the methodology of the Atlas, where we say, and Irini also mentioned them today, and I think, and myself, what are the criteria that provide a good quality study, the diagnostic criteria, how recent, and the sample size, but how to conduct an epidemiological study. I think that guidelines from the IDF that can be found in the Atlas website and the course from the IDF school, it's a good resource to address that.
Also, our latest publication has a lot of material from Lancet. We in detail discuss how we do the analysis, the meta-analysis of the data sources in Atlas. So you can always reference this article.
Great, thank you, doctors. And the following question is for both of you as well. Why the adult age group from 20 years old when 18 years is the considered age as adults in clinical trials?
It's the age group. It's since the first edition is the same age group, so it's also to be consistent. But I think from 0 to 19 years old is described as children and adolescent. Adolescent is still until the age of 19. So until the age of adolescent, it's not mainly type 2 diabetes. Type 2 diabetes is more prevalent after the age of 19. So wanted to gather the total diabetes data, and with this way to describe the type 2, we have to take from 20 and up, because until even the age of 19 is still adolescent. So that's the reason we start from 20 and up. And I think the 20, do you say why we reach, it's 20 to 79, and 79 is because most of the surveys are up to that age group, is not usually above the 79 age group. I have to say that it's one of the discussions that after 25 years of Atlas, that maybe we should revise this age groups and based on the data available. But for now, that's the reason we are selecting the 20 years old for, because before it's children and adolescent, and after that age group is mainly type 2 diabetes.
Thank you, doctor. So for, again, Dr. Irini and Evie, how do you address possible role of ethnic differences on complications or other points of interest in data, and that does not segregate the ethnicity?
Yes. So again, I think there has to be enough data sources to paint a picture and say these are the estimate per ethnicity and be accurate. So if there is not enough data as Atlas, we cannot say that this is the picture. From time to time, I think I have to say that we gather this data. We gather data by ethnicity, and maybe we will evaluate whether there is enough data. For example, 2 years ago, we have an IDF Diabetes Atlas report on indigenous populations. So we had a specific estimates and on diabetes prevalence for indigenous populations. So when enough data are available, we also produce this kind of reports. But I think, yes, the main challenge is to have enough data per ethnic group. If you want to paint a picture in the world, per region, per country, then it's challenging.
Also, ethnicity is something that is considered when extrapolation groups are defined. So ethnicity is one of the characteristics that domain experts take into account when they decide which countries are similar to others. So in its edition, this is revised and it's taken into account.
Great. Thank you, doctors. So the following question, how can countries better contribute to the development and improvement of the Atlas? It's addressing both of you as well.
I think it's what we discussed, and it's if there are not in place surveillance systems for capturing the surveillance system, meaning the National Health Survey, registries, standardize the diagnostic criteria. So I think this is what we discuss applies to here for the development of the Atlas. If there is a good surveillance system is in place, if there are national health surveys, if there are publications on the diabetes prevalence, this is the best way to help the Atlas provide accurate estimates.
Yes, limited data is the main problem to have credible estimates. So this is the first thing that has to be addressed. And then there are many other levels that you can help the Atlas methodology according to everyone's role. For example, the analysis of the Atlas using different models can drive different estimates. So research in this direction can also be helpful for us.
Great, great. Thank you, doctors. And now we have our final question, and it's addressing everyone. If there is one action you would like the audience to take after this session, what would it be and why? You can start with Dr. Irini.
I think this is similar to the previous question. This whole webinar is about encouraging data source collection and quality data sources. And that's the first thing that we want to people from this webinar to think and help us with. And then there are many other directions that the methodology of Atlas can be improved. And everyone's role is different. So there are many different levels that they can help the Atlas and the Atlas analysis.
And what about you, Dr. Yes.
I agree. For today's webinar, for me, that's the importance. If you have and are aware of data in your country that you can share, please visit our website. There is the link there on the first main page, how to submit your data, what kind of criteria. And it's your, everybody's contribution is very important. And yes, and my next message was like, I'm happy to see that that the Atlas data are really helping, changing policy of the diabetes used by the diabetes community, people with diabetes and advocates like you, Iman and Pedro and Evgeniy. So I think that's an important message as well.
Would you like to add, Evgeniy?
Me, yeah? Evgeniy. My name is Evgeniy.
Yeah, the question is addressing everyone. Yes.
Yeah, it's okay. I was thinking what to suggest, and I would refer more to people who live in this type 2 diabetes. Cheer up, cheer up. There is a hope. There is opportunities, and for all of the community, yes, it's difficult, but for me as an optimist, seems like solvable. But hopefully, this will be a small beam of light for today's webinar. Thank you.
Thank you. And from my end, I would just simply add that I would ask everyone to educate themselves about the condition, about what the IDF is all about, what the Atlas is all about, because it starts with your eagerness to learn, and then you will find your way around webinars and tips and tricks about how to share, what to share, and how to contribute to the production of Atlas. And I guess this is the final session of today. Thank you so much for joining us for this webinar, and just sharing some closing remarks about the webinar, and reminding you all that the recording, slides, and feedback questionnaire will be sent to everyone registered in a few days. And please respond to the feedback questionnaire to help us improve future IDF online events. And if you have any question, you may send them to the email mentioned here, advocacy@idf.org. Thank you so much for having us. And the next webinar is going to be in the International Day for Maternal Health and Rights, Evidence, Technology, and Equity, Rethinking Diabetes Care in Pregnancy, and it's going to be on the 13th of April. Please don't forget to register and attend. Your contribution is very important. Here you go, the QR code, and we look forward to seeing you all there. Thank you.
Thank you. Bye.